All right, welcome. This is a mental health review. Since it's just Erica and I, we decided that we're going to do two case studies. The first one is on suicide, kind of suicide prevention and involuntary admission. So I'm going to have Erica kind of go through these case studies, and I think she's going to do a fantastic job, okay? And these are next generation NCLEX kinds of questions. So just to get you ready, right? We're just in that NGN frame of mind. Okay, Erica, take it away.
Okay, do you want me to read it?
Sure, please.
Okay,
Thank you.
case study. The 19-year-old female was treated in the emergency department for an oxycodone overdose. We're going to click the three findings that are most urgent. So the note says the client was brought to the emergency department by ambulance, accompanied by her brother. Client's brother found the client unconscious on the bathroom floor with an empty oxycodone bottle. The brother reports that the client is struggling with moderate depression after the sudden loss of their mother. And this is the client's second suicide attempt in the last 6 months. Client's brother reports that he is very anxious about the client returning home because there are guns in the house. Yesterday, he overheard her say that she had a plan to use the gun to end it all. The client was treated with naloxone in the ambulance, but doesn't say how much. Upon arrival, the client is lethargic and confused. Makes sense. Second dose of naloxone given for respiratory rate less than 12. Makes sense. It only works for so long. 1800. Respiratory status is overproved. Client is alert, oriented, but agitated and pacing in the room. Admits the overdose was intentional and stated, I just want it to be over. Client is voicing concerns about being in the ED and is looking at the sharps container on the wall. Well, she's not in a lockdown room. States that she has no insurance and won't talk to those people again. Vital signs at 1700, temp was normal, pulse was 50, oh, because she was unconscious. Respiratory rate was 9, so they gave that second dose. BP was 100/65, pulse ox was 92, pain is a 0, which makes sense, she took an opioid. At 1800, temp was the same, pulse is 65, respiratory rate's now 12, BP is 111/75, pulse ox has come up to 95% and still 0 pain. Now the hard part, now we have to mark the 3.
Yes.
I would highlight the yesterday he overheard her say that she had a plan to use the gun to end it all because that's an absolute suicide. She has a plan, but I don't know if it'll let us. This is hard.
No. And so this is the thing. So the three findings that are the most urgent. So the things that you need to handle right now in this moment.
Okay. Um, Klein is voicing concerns about being in the ED and looking at the sharp container on the wall because apparently she's not in a lockdown room.
Okay, so you want that to be, let's see. Okay.
That, yes. Um,
Okay, let me stop you there, because you say the lockdown room, and talk to me about that a little bit, because I feel like you know what that means. I know you have emergency room experience, so what does that look like?
Yeah, so typically it's a room. I know in the Centeras and like Bon Secours, it's either an empty room, or it actually has like a secondary wall, almost like that would like so say all the monitors and the sharps container were right here, any supplies. It's like a wall, like a garage door almost that you can pull down. So that room, you're not gonna have any sharps, you're not gonna have any cords, you're not gonna have any lines, you're not gonna have anything that could be potentially dangerous. The glass isn't going to be breakable. You're going to be able to see in the room from the outside. And typically, when we take a patient into that room, we remove all their clothes and things like that. They'd put on a gown without ties. The whole idea here is we want to keep that patient as safe as possible. We're going to remove any potential hazards that that patient could use to harm themselves or someone else. So typically, I'm talking super, super bare room. Now we're going to put
Yep.
them in a room because we want them to have privacy, but we call it mental health or lockdown rooms because you can literally lock down anything else from the patient. It's a bed, a blanket, sometimes, and they're in a gown.
That's right. And in some places they don't even have a gown, they have scrubs that they
Right, the
wear.
paper scrubs.
Right. I'm glad that you're kind of painting that picture because we think about, okay, what is the basic that they need? Okay, the basics that they need. Okay, awesome. So we got looking at that sharp container. So definitely I agree with you there.
Okay. I would do admits the overdose was intentional
Okay, admits the overdose was intentional. Okay, for sure.
because she's got a plan. This last one, it's not most urgent. I'm still concerned about the respiratory rate, but that's like she was given a second dose of Narcan. That's not uncommon. I'm going to expect in another hour she's going to need another dose of Narcan or maybe a Narcan drip. But I don't know if that's urgent enough. But it's very typical that you get more than one dose. But you could have a nasty, nasty rebound effect.
That is true. That will really be more severe than the first time that she had a reaction. So you're
And that's
absolutely
the
right.
problem. Pre-hospital or when people come in and they're given Narcan and then they check themselves out, there's a good chance they're going to be found an hour later unconscious again.
Okay,
Um,
so let me ask you this, Erica, because you brought up a great point. When patients check out, will this patient be allowed to check out?
She should not be, no, because she has
That's right.
clear SI. They can easily get an order to keep her there and do a 72-hour hold. She has a plan. She verbalized the plan yesterday to her brother. Today she went through with the plan. She says it's intentional. She says she wants it all to be over. This is our classic patient that we can keep there because she's a huge risk of harming herself.
Okay, absolutely. And so that's really well said. And so based on what you're saying and based on her vital signs, it looks like they're pretty much stable right now.
Yeah, that it's come up, but they look great right now.
Okay, so what's the other thing that is going to be the most urgent? If her vital signs are stable, where okay, her physical needs are okay, like
She's
we
still
know.
agitated. I don't know how unsafe she's going to be towards the provider and if she's going to be
Hmm.
willing to follow directions. So that's probably what I would. I don't care that she doesn't have insurance. I Nobody wants to be in the ED, but the fact that she's agitated means she's probably not going to be compliant with anything we're doing.
Okay, awesome. And so you're definitely on the right track. And so I put the rationale into the chat. And the big
Oh,
thing is that, and I just put it in. So I just want it to be over. So this tells me
okay.
that she is still at risk.
Yes.
Even though, she had the attempt and it's not like, okay, I'm okay now. No, she still has those feelings. So her safety is going to be the primary thing that we're concerned about because vital signs wise, she is stabilized. Okay, even though, her pulse is on the low side, her respiration is on the low side, but it's still within normal limits. So technically, physically, she's okay to be alive, okay,
Yes.
and safe. Now, when we look at the rest of it, looking at the psychosocial piece, that's now where we have to, okay, this is not a safe patient to be left alone. She has to be kept against her own will. And she says this was intentional. She has a sharps container, so she needs to be in a room that is a setup for suicide precautions. Okay. Okay. So those are the three things that are the most urgent.
Okay.
Okay. All right. So great job. Thank you for kind of walking through that. All right, let's go to the next. So it's the same kind of note. And I know that we talked about this before, and I've been working with some other students too to make sure that you don't miss anything that is new. So the vital signs are still the same, the note is still the same. Now let's go to the question, and I'll shrink it down so you can see everything at once. Okay, so the toxicology report returns and is positive for oxycodone. So for each finding, click to specify what risk factor the client has for suicide. Okay, so tell me as you go through, risk factor or
That's
not a risk factor.
previous suicide attempt is definitely a risk factor. Recent loss is a risk factor. That's a major stressor. 19, she's right in that age of our peak. Gosh, that's gonna I feel like 19. I don't remember what the peak age for suicide is, but I feel like 19 is in it. I could be wrong. Do you have the rationale for that? That's gonna drive me nuts. It's probably
I do. We're gonna go each of the over when you finish. I'm gonna
is
let
it
you
is
have
it
yours.
20? I feel like it might be a hair above that, but I don't remember the numbers. I would say 19 is not right now, but I could be wrong. I don't know the number. I need to know that. Um,
Okay, so you're
weapons
saying
and
it's not a risk factor.
yeah, but I feel like I might be wrong. Like schizophrenia is diagnosed between 15 and 25, so now I'm second guessing myself. But we'll go off that. Weapons and home, that's definitely a risk factor. She has access to it.
Okay.
No health insurance. I'm gonna overthink this. Um, yeah, that would be a risk factor. She has depression. She doesn't have insurance to get treatment for it.
Okay, so you're saying no health insurance is a risk factor?
For her,
Okay, all right. So, and this is a really good question, and I'm putting the rationale in the chat. So, per the CDC guidelines, the suicide risk factors, they're going to be previous suicide attempt, and that patient really for 1 year afterwards, that initial attempt, they're at great risk. Okay, if they have mental health issues or mental illness like depression, bipolar disorder, schizophrenia, they are definitely also at risk. If they use substances such as alcohol, and I'm talking about substance use disorder, alcohol or street drugs, they are at risk. And so previous suicide attempt, you are correct. That is a risk factor. Recent loss, that is a risk factor as well. The age is not a risk factor. So you're right. It would be younger. It's, the teenage, I think up to 18 is the cutoff point. So 19, not necessarily a risk factor.
okay, I
And
knew she was literally on the border. I knew it was either one up or one down, but I could not remember.
yes, yes. Now, anybody that's listening to this video, if your textbook or your instructor told you something else, make sure you go with that because I don't have your mental health textbook in front of me.
You know what?
So,
I do
oh, okay. Well, let's pause for a second to check
have it.
that out.
Let me look real quick.
Okay, yes, that's great because and you can also say the page in case they want to look that up. And I know that was probably on exam one, but is your exam for mental health comprehensive?
The HESI is. So I would assume it's all comprehensive because it all kind of builds off of each other.
Okay, so I think it's worth pausing and taking a look.
Okay, I'm looking
Okay.
right now.
All right, thank you for that. And while you're looking, okay, weapons in the home is definitely a risk factor, and no health insurance is actually not a risk
Okay.
factor. Okay. And I know your reasoning, it was like, oh, well, she can't get the help, but that's not necessarily the risk factor that we're looking for because sometimes people do have health insurance and they still can't get the help. Because mental health sometimes resources are difficult to come by. Okay.
Okay, so the age adjusted suicide rate has increased, all this. Comorbidity, biological factors, genetic, neurobiological, cognitive. Because on here it says it's the second leading cause of death for 10 to 34-year-olds, and then the fourth leading cause of death for 35 to 54. But I'm trying to see the actual contributing like factors, what the
The
official.
age.
Oh, okay. Risk factors include family history of suicide, family history of child maltreatment, previous suicide attempts, history of mental disorders, particularly clinical depression, which she has, history of alcohol and substance abuse, feelings of hopelessness. So, our book, I'm scanning again.
Mm-hmm.
I don't think we have an actual age listed. And this is chapter 25. All of 25 is suicide and non suicidal self injury.
Okay,
So,
and I'm looking at the CDC website
mhm.
to see what they say. Okay, what are the risk factors? Previous suicide attempt, history of depression, serious illness, chronic pain, criminal legal problems, jobs, financial problems or loss, impulsive or aggressive tendencies, substance abuse, current or prior history of adverse. So everything that you said actually. Um, let's see, societal. It doesn't really give an age
Mine
range.
doesn't either.
So that's a tricky one. So I will tell you the truth. If I was the classroom teacher and I'm not the classroom teacher, um, I would probably give credit for that one, that 19-year-old, just
Okay.
because I'm kind of on the fence. So this would be a question that I would ask my classroom teacher, like, one of those before the tests, or if she has, or he or she has office hours, because
Yeah, I
that
have a review with her at 8 o'clock tonight. So
okay.
I'm just gonna ask her, I think, before we start.
Yes, and you can just tell her, you know what, I was doing this NGN case study and this, and you can take a screenshot of it if it's going to help you. But I think that that would be great, and I'm interested to see what your instructor says, because I kind of feel that 19, I would give credit just because it's still so close. Okay, all right.
Okay, no, good to know. Thank you.
You're welcome. All
So
right. And so we'll see what the
at
answer
least we know
comes
that
out
one.
to be. Okay. But everything else was good to go.
Okay.
Okay. All right. Let's look at the next set of questions here. So this is question 3, and I'm going to make it a little bit larger because we have some more information that's available. Oops. Okay.
I
Can
love
you
when you're
see
changing the
this
word.
okay?
Yes, I can.
Okay.
So, all right. So now we're gonna drag the appropriate word choices to fill in. Let me set this down. Sorry, Charles. All right.
Okay, and so
Top.
just if you highlight the new information, what's new now in this the vital signs and the lab report? Because we don't want to
Okay,
miss that.
so the new lab report is just that she was positive for oxycodone, which is important. We need to know what she took because she might have taken something else with it. And if you've taken different types of drugs, that could affect our treatment. Narcan
Mm-hmm.
only works on opioid overdoses. So if she has something else in her system, like with her pacing, I there could have been a chance she had a methamphetamine or something else in her.
Mm-hmm.
So now we know that, and then the nurse reviews the client assessment data and risk factors, drag the most appropriate word from the choices to fill in the blank. So the top, okay, so we're going to choose one. The top care priority for the client is going to be whatever says to keep them safe. So implement suicide precautions.
All right,
That's
excellent.
our number one. We're going to keep her safe.
That is correct. And I just want to make sure that we look at these new vital signs for
Oh shoot.
1830. Right.
Okay.
So we don't miss that because this tells me that, okay, wow, her vital signs are even improving because I know you had a
Getting better.
concern about that respiratory rate was a little low.
And her
Um,
pulse ox, if it trended downward, but
mm-hmm. But
she's
she's,
stabilizing for sure. So
yes.
now,
Okay.
if that had changed, the respiratory rate had changed to 10, our top priority would have been respiratory status because we're worried about her being alive,
Yes,
breathing. We're worried
absolutely.
about airway at that point. But now that ABC is good, we need her to be safe.
Yes. And so like this is a huge point, and I want to make sure that anyone again that's watching this video understands and sees how to look at the trends of these vital signs. And I know before you brought it up, you're like, man, I don't love that her, vital signs are not good, but they're even though within normal limits. But now we have 30 minutes later, her vital signs are actually pretty doggone good, right?
Yeah.
So this makes me feel that she is safe physically. Now we could attend to those psychosocial needs. And the safety is going to be what we have to focus on now because she's kind of out of the woods as far as the vital signs and everything's showing. And I know I keep reiterating it because that is a really important point, and sometimes we can kind of miss that. Okay. Anything you want to add to that, Erica, since you did so well picking that so quickly?
I don't think so. I'm just happy that we're trending upward and all of that because that makes
Okay.
our top care priority is always going to be to keep her safe. But if she can't breathe, it goes to airway. But
Okay.
she's breathing beautifully.
Okay. Excellent. Okay. Let's go. Question number 4 now.
Okay, orders. Yep, and then there's
Okay.
our sitter order, which I expected.
Okay. Awesome. So what is sitter orders? For those that may not know what sitter orders mean, what does that mean?
So it's number three, that implement one-to-one observer. This is going to be a patient who has someone sitting there at the doorway watching them at all times.
Okay.
To
Awesome.
keep them safe, they're going to chart on them. Usually it's within every 15 minutes. Their behavior, are they cursing out? Are they crying? Are they agitated? Are they trying to choke themselves? What's that client doing behaviorally in that room? They don't necessarily have to be medically trained. A lot of them aren't medically trained, but they're safety trained.
Okay, that's right. Okay, great. And I'm just asking you to emphasize that because number one, I know you know what it is, but for anybody that's viewing, if they're like, what is one to one? But you explained that beautifully. Okay, awesome. So what's going to be indicated or not indicated for this patient
Okay,
based on the
we're
orders?
definitely going to remove all sharp objects from the room.
Mm-hmm.
We don't need to consult the chaplain right now. She already said she wasn't going to talk to people. We're not going to tick her off. Remove
Mm-hmm.
unnecessary cables, cords, and equipment. That's definitely indicated. We're going to conduct frequent safety assessments. That's the whole point of having somebody there. Take vital signs. We're not going to take them every 5 minutes. She's stable right now. Not indicated. That's a good way to tick somebody off.
That's
We're
right.
definitely going to screen visitors. There's a good chance they're not going to allow any visitors in this crisis, but her brother is there. And it's not indicated to apply restraints at this point. That's not an, I mean, that could be considered later if depending on what happens, but right now that's not indicated.
Okay, excellent. So you did a great job breaking this down, and I'm going to put the rationale in the chat just for you to review it. And I like what you said about the vital signs. No, we're not going to do that because she's actually now she's stabilized. Let's talk about screening visitors, why that's so important. Because you don't know if her friend is going to come and slip her some drugs or slip her something that she could use to harm herself. And for anyone that is having clinical in a mental health kind of setting, like an acute setting, you know that everyone has to be screened. And sometimes they even are searched and wanded before they can actually go in. So like for Virginia Beach Psychiatric Facility that's right across the street from Centera, Virginia Beach General, you have to actually be searched, patted down, wanded before you can go through. The same thing for Norfolk General, their behavioral health unit. So that's really, really important because we don't want those visitors to bring anything that's unsafe. Okay, so let me just mention what's going on with the orders. So the orders are implementing suicide precautions, and Erica had already mentioned what all of those things look like. If you're not 100% familiar with suicide precautions, please look that up in your book to make sure that you're good to go. Suicide assessment risk Q 1 hour. Q means every hour. So we're going to be completing that flow sheet. The one-to-one is a sitter, a safety observer that will be documenting every 15 minutes and then transfer to behavioral health. And that is an example of that would be Norfolk General, the 8th floor. That's a behavioral health unit. Okay. All right. Excellent. Okay. So this is question 5. And there's more notes. I'm going to give you a chance to kind of look at those notes. Okay, hold on, Erica, you're muted. So, okay,
Sorry. Okay,
that's
so
okay.
1900 client refuses to be admitted to the behavioral health unit, provider notified. That's standard. So then they're
Mm-hmm.
going to go ahead and get that 72-hour emergency order. And it says 1930 emergency detention order. Usually they can just call in for that. It's so somebody's available. And the nurse just needs to, that's where your nursing notes become really important because you need to have direct quotes and different things and paint a picture for the magistrate or the judge or whoever. The client said this, the client admitted to this, because that's really what's going to help you help your patient. So
Okay.
literally half an hour later, they got that order. Um, it says the client refuses to be admitted to the behavioral health unit. An emergency detention order for involuntary admission to the behavioral health unit is obtained.
Uh-huh.
What should the nurse teach the client about the process? Okay, good. Of an inpatient, because they still get choices. They just can't go anywhere.
Right. And so this is a patient that will be held against their own will because they are a danger to themselves or a danger to others. And in this scenario, this young person is a danger to themselves. So this is a select all that apply, and I'm standing by to check the ones that you say I should check.
Okay, so first and foremost, yes, she has to be a risk to herself or others. That's a yes. Let's see. Let me keep reading. Okay. Um, the client has the, let's see. Sorry. Yes, she has the right to refuse a physically intrusive research. Yeah, she doesn't have to participate in research. They can be
Mm-hmm.
admitted for up to 5 years. No, that's not true. The client should seek legal counsel. No, that's not true. Family and friends are unable to visit. That's not true. A lot of places you can, they screen them. The client must receive verbal and written notice of the rights. Yes, they have to tell her what's going on, and at every psych facility you go to, usually it's posted in common areas in your room wherever the patient writes. So just because she's being held on an involuntary basis, she still has a say in her care. She still has rights.
Okay, yes. Wow, that was picture perfect. So I put the rationale in the chat, and so you broke it down picture perfect. I don't really have anything to add. And it's funny because this is the perfect scenario for you. Okay, awesome. Okay, so this is the last question for this 19-year-old female.
Okay.
And again, looking at the nurse's notes, we have already seen the new notes. The vital signs are the same.
Okay.
Lab reports are the same. The orders are the same. So here's the question.
Okay. For each client statement, click to specify whether the client statement indicates an understanding or no understanding of the teaching Friday. Okay, good. So we've done education. So I can go home after I take my medications. No, she doesn't understand. You're gonna be there longer, sweetie. My brother can visit me. Yes. I will not be able to see my best friend while I'm hospitalized. Not necessarily. No, she could have visitors. Even though I
Okay.
want to go home, I must stay. Yes, she understands. She understands. Okay. If I promise not to take any more oxycodone, I can go home. No.
Okay.
Because of my depression and suicide attempts, I must stay here and get help. Yes. Because you just did this, you are now on a temporary order and you have to stay there.
Okay, excellent, excellent, excellent. Okay, so I think you've got all of them. Um, Absolutely. So understanding, no understanding. So this is kind of like your positive, negative questions. They just kind of flipped it around. And so I just want to mention this is like how are they scoring? This is like the 0-1 scoring rule.
Okay.
So you can't really miss any of these, I think,
Okay.
in order to get the points. Okay, all right. That is the last question. So that was great. This was question 6 out of 6. So how do you feel looking at this scenario?
Okay, this one I feel really good about, but I've dealt with this a lot. I'm not as excited for the next one.
Okay, well, and you did a fantastic job, and it was kind of cool because I know you're an room kind of nurse, but let's see how this one goes. This is going to be another mental health one. This is on bipolar disorder.
Okay.
Okay, so I'm going to try to squeeze it in because there's a lot going on with this patient on this question. Can you see everything okay?
Yeah, I can.
Okay, perfect.
Okay, so 23-year-old male with bipolar disorder has a health maintenance appointment with a telehealth nurse. Okay. Telemedicine visit. Client appeared on screen in a positive mood, was well groomed, shaved, clothes neat, non wrinkled. His speech had a normal cadence, was organized and logical, no slurring or stuttering. Oh. Occasional tongue thrusting noted while speaking that he was reported to have starting 1 day ago. Fine hand tremor noted when the client smoothed hair back during conversation. Client reports that he's still attending school and is doing well. He's working a part time job on the weekends for a local restaurant. States that he has been taking his meds as directed and he has no thoughts of self harm, but he has difficulty sleeping more than a few hours per night. Okay. He complains that he has gained weight 10 pounds recently and has not had the energy to work out. Self obtained home vital signs of 128/72, heart rate of 82, and respiratory rate of 20. So lithium work, which is expected. He is a bipolar, is his diagnosis. 900 milligrams twice per day by mouth at 0, 8, and 1800. Risperidone 2 milligrams once daily at bedtime by mouth at 2100. Okay, so looking at his labs, cholesterol is borderline. His bun is fine. His creatinine is fine. His fasting glucose is definitely on that border of prediabetes and diabetes. His hemoglobin A1C is normal though, but he's teetering on that pre-diabetic and he did gain weight. So that'll be something we have to consider later on. Hematocrit's okay, hemoglobin's okay, white blood cell count is okay, platelets are okay, potassium is great, serum sodium is good, lithium level is 0.8 on the lower side of okay. All right. All right. So now we're going to do the 4 clinical findings that need follow up: tongue thrusting, fine hand tumors,
Okay, tongue thrusting, fine hand tremors, you say? Mm-hmm.
difficulty sleeping, and then I don't love. hmm, Did I already put difficulty sleeping over there? Yeah, I'm gonna do the weight. That's a lot of weight gain recently. We're gonna do the weight gain because he's on meds. Like I expect some weight gain, but he's on meds and some of them are very weight dependent as well.
Okay, so excellent point. Okay, and I want to apologize. I realized that I was putting the rationales in the chat, but they were going to the waiting room. So I was like,
Oh,
she's
I
not
see them
seeing
now.
any of the
No.
rationales. Okay, so all right, great. So you did a great job. I really like your style, your structure, how you went through the notes, you kind of thought it through, and even though we're together, you're kind of talking and it's out loud, but I'm sure this is the same way that you use your internal,
You
you
should
know,
see me during tests. I'm like,
yeah, but no, that's fine. And so what you're really demonstrating is a good way for someone to kind of break down these questions and kind of think it through, even though they won't be saying it out loud, right? But this is the internal dialogue that they should be having. And so you're kind of going step by step, you're looking at the lab results and you're thinking, okay, this is a problem. And so that's a really good strategy. The way that you're doing it, I think is excellent. Okay, so let's talk about the findings. And so this is going to be 4 findings that need follow-up. Now, it didn't say this is like life and death or anything like this because this is not an immediate threat to danger. But
right.
the things that are not within normal limits or things that are a little concerning
And a
is
couple of those freak me out because I'm immediately thinking bipolar, he's on meds. These meds can have side effects. A couple of them are, these are major side effects that we need to.
act. Yes. Now, the tongue thrusting, yes, because that is a telltale sign of tardive dyskinesia. So that definitely. The fine hand tremors, not so much. So we don't necessarily have to follow up with that right away. But the cholesterol being 220, yes, we
Okay.
do
Okay.
have to follow up because we know that 200 is the number that we're looking for. Even when we look at the reference range, we're looking at, okay, we want it to be less than 200. Because what is the danger if a patient's cholesterol is too high? Okay, hold on, Erica, you're muted. I'm sorry.
Sorry.
That's okay. That's okay. So what's the danger? Why is that really important, the patient's cholesterol, because it's 220?
um the I mean, no one should have high cholesterol, but I'm worried about having cardiac issues down the line and things like that. There's a reason we're giving people meds, but with the weight gain in that, I don't want this patient to have cardiac issues later on, build up that plaque and those things.
Right. I'm afraid of atherosclerosis. And with high cholesterol, now we have cardiac issues. And you already noticed that they could be, on the way for pre-diabetes. And so that's kind of like what I call, in the military, we have the deadly force triangle, but in nursing, we have that deadly triangle. One leg is, cardiac disease, which is your hypertension, your high cholesterol, then your diabetes. And to me, that is the deadly triangle for your patients. Okay. So that is definitely something we need to look out for. And then the difficulty sleeping, you were right. That's also a cause for concern, because that can affect so many things. Improper sleep cycle and the patient not getting enough rest is linked to diabetes, is linked to heart disease, is linked to depression. So all of these things are linked to this difficulty sleeping. Okay, so these are going to be the top 4 findings: the tongue thrusting, the weight gain, which is a considerable amount of weight, and the cholesterol and the difficulty sleeping. Any questions about these that need follow-up? No. Okay, all right, let's take a look. All
Okay.
right. And we've got the notes, the medications, and I don't think we had the medications on the last section.
We did. It was at the beginning because
Okay. All right. So the lithium, the risperidone.
only
Okay, yeah,
thing
that's
different,
true.
okay, is just which clinical finding of the ones we found. It's going to be that tongue thrusting
Okay,
because he's
awesome.
experiencing side effects from his antipsychotics. So we know we
Yes.
need to do something about that.
Yes, excellent. And so I would submit to someone if they don't know what tardive dyskinesia looks like, that's where you can Google a video, Google an image, and that will help you. So once you see that, you will be like, oh, that's what it is. Okay. Okay, great. We're going to the next question. Everything appears to be the same. So these are two drag and drop kinds of questions. So go ahead to do that.
Okay, the nurse should recognize that the client is most likely experiencing tardive dyskinesia. That was easy. And then caused by, it says antipsychotic medications. That's telltale what's causing it. And we're always worried about these EPSs with any of our psych meds.
Okay, awesome. Okay, and that is correct. Okay, and so this is really easy because you know the side effect of antipsychotic medications and you know what tardive dyskinesia is. Sometimes I encounter students and they have no idea what tardive dyskinesia is. So like this is really like one of the top 5 things that you need to know about mental health besides therapeutic communication. Like tardive dyskinesia is a big topic for you to understand, okay, and be able to identify. Okay, but you did excellent. All right, let's go to the next question, number 4. Okay, and I did put the rationale in the chat for real this time. Okay.
Awesome. Okay. The nurse concludes the client is most likely experiencing tardive dyskinesia. Great. I like this on next gen because you can see if you're at least semi right or not.
I know, well, and it's kind of good, but then it could be bad because you're like, because you can't go back.
No. Okay. Which two interventions did the nurse anticipate including in the plan of care? Discontinue, repair. Yes. Yes, because that's probably what's causing it.
Okay.
We're not going to decrease that lithium dose. We're already at the bottom of normal, and we need that lithium to work properly. Obtain more frequent lithium. No. Order for low salt. Not yet. Monitor for other extra pyramidal. I can't even say that word. The bottom one. I want the bottom one.
Yes, the extrapyramidal symptoms. Yes, absolutely. Okay, so you got that correct because now there's tardive dyskinesia. What are some of those other things that we're looking at identifying or monitoring for in this patient?
It's like our jerky movements, abnormal facial movements. Um, I think some of
Okay.
it can be speech too, but I don't really know. I know that there's a chart in our book of like paperwork, yes, aims, where you um that's gonna bug me.
Okay, so that's
On page
great.
210, there's a
Okay.
chart.
Yes, and
So
I'm
your
gonna
facial and oral movements, I cheated. Your trunk movements, that kind of thing. So I'm looking at it now because I've seen it before.
mhm.
Um,
Yes, and you need to know that when it comes to these extra movements, and it is the Ames scale. Okay, I'm trying to find one so I could actually bring it up so you could see it. So let me just bring that here. So you should see an actual kind of, okay, this is the sheet. Obviously, this is a checklist one. Okay, and that's the same thing that's in your textbook. Okay, awesome. So say that you said page 210 in the textbook, the mental health
page
book.
210 in our textbook, yes.
Okay, awesome. And so let's kind of run through this Ames scale. Sometimes you may, if you're lucky, if you have the kind of clinical where you can see this, and we're talking about the facial muscles moving, the lips, are they, puckering their lips? Is their jaw moving around? Is their tongue being stuck out, right? And sometimes they're moving their hands, their fingers, and you mentioned those jerking movements. Is the person even aware of these movements? Because they may not be aware of them. Okay. Okay, and the neck, shoulders, and hips. So the patient will be rated. This is kind of like when we think about skin assessment, the Braden scale, it's the same kind of thing. CWAP protocol is another kind of scale that we're going to be grading, the patient. Okay, so the Ames scale goes along with this. Okay, all right, so that's great. All right, question number 5. Okay, there's a little bit of update with the meds, and I'll let you kind of walk through that.
So they went ahead and discontinued that risperidone. You can see that's crossed out, discontinued on the 1st, which is the same day as because he's on a telehealth appointment. He's not at the hospital. We're on a telehealth appointment. So she's making these changes, this advanced practice person or doctor or whoever they're with. So, okay. The prescriber discontinues their risperidone and the nurse teaches the client about the treatment plan. For each possible action, click to specify if the following client education is indicated or not indicated. Okay. Monitoring for uncontrolled oral facial movements, that is indicated.
Okay, good job.
Monitoring for change in mood and or suicidal, yes, because we're stopping this antipsychotic very quickly. Changing to a high protein diet, no. Maintaining adequate water, yes, they're on psych meds, yes, please. Lithium, drink all the waters. Changing to a high fiber diet, no, fiber is not really the issue. Changing to a low salt diet. We have cardiac concerns, but his serum sodium and everything was fine. And sodium, potassium go hand in hand. Everything's fine. I would say not indicated, but he probably needs to follow up with a nutritionist.
Okay, great. So I love everything that you said, Erica. And again, I like the way that you were kind of, walking through everything. And I just want to highlight some things about your patient that's on lithium. They really should not change their salt intake. They need to have a normal salt intake. So the low salt diet will actually do more harm than good. So I also like, though, that you were like, I'm going to send them to a nutritionist. Again, because of that cholesterol, because of the weight gain. And so you understand that there's side effects of the medication, but you also understand, okay, the other health implications that could go on, that could happen down the line because of those lab values. Okay, but you did excellent and your critical thinking is spot on. All right, this is the last question for this scenario. Uh,
Okay, added notes on 6-1.
Okay, there we go. I'm gonna make it a little larger. You can see it.
Oh, good. They had an in-person visit. An in-person, I would expect this follow-up to be in person because they want to see the whole body. They need to see his movements. So this is good. Okay. In-person visit vitals. Oh, are a little high. 135 over 72. So that's trended up. Heart rate 82, respiratory rate 16, temp 98.6. Appears unkempt, wearing a ripped t-shirt. That's not great. Speech is slurred and slow. I don't like that either. No tongue thrusting or other uncontrolled oral facial movements noted, so that's resolved. States he's been able to work for the past 2 weeks and is taking a break from school and work. I don't like that. Okay, says I don't really like work anymore and school is a bore. Reports taking his meds as directed. Denies thoughts of self-harm, good. He has lost 5 pounds since the last visit. Okay. Good on some things, not good on other things.
Mhm.
Let's see if any of his labs have changed. They don't have updated labs.
Okay. All
Okay.
right.
Okay. So for each finding, click. Okay, we're going to evaluate the effectiveness of the treatment plan. For each finding, click to specify if the finding indicates that the client's status has improved, declined, or unchanged. So no suicidality noted. That has not changed. He wasn't suicidal before. Slovenly appearance, that's declined. He's unkempt now. Now he doesn't look good. No
Mm.
tongue thrusts, which that's going to be a problem because now he sounds more depressed. That's okay. No tongue thrust has improved. Taking meds as orders, unchanged because he's always been compliant. Stop going to work and school. That's declined. He used to go, he was tired before, but now he's not going. Now it sounds like we're headed down the road of depression. We're headed into that phase and we don't want that.
Okay, awesome. So you did a fantastic job, and I know you're just walking through this. It seems like easy peasy because you kind of have a background in this. So anybody that's watching this video might be like, "How did she know that?" But you picked up on those clinical cues, right, with that slovenly appearance, and you remembered the presentation of the client previously. And what I like about these case studies is we can see the scenario develop. Okay, so but all of those things that you checked are correct. Okay, the last question is going to be, oh wait, was that? No, that wasn't the last question. I think I missed something because the last question should have been a bow tie question. Okay, let me see. What did I
Oh,
click?
we have those on Hearst. I know what you're talking about. I hate them, but we have them.
Yes, okay. Oh, that was the bow tie question. Okay. Okay, that was the bow tie question. No, actually, I don't think it showed up for some reason on yours. There was supposed to be a bow tie question. Um, so let me just see here. What happened? Why didn't it show up?
That's the one that has like potential conditions, right? And then what you're gonna do for it.
Mm-hmm.
Okay.
Yes. So, and I'll just kind of run you through with this bow tie. I'm going to put the rationale for the bow tie in the chat also. And so the bow tie basically, let me see if I could, I don't know if I can, let me try to download this. Hold on one second to see if I can get that because I think that would really be like a nice icing on the cake just to talk about the bow tie. Okay. And give me one moment here. Try to, because I thought we had 6 questions, but
These are good. Hopefully there's
is
more. I like these.
yeah, there's a whole bunch. Like I was so excited when I found this test bank. Okay, and definitely sharing it with everyone. I love to share when I find something good. Okay, let me see here. Okay, I'm going to share my screen again so we can kind of walk through this. Okay, oh, did it go all the way? I want to go to the end. Okay. Okay, we did that already. Okay, we did that. So, okay, so this was the follow-up that we went through. And you kind of talked us through that. And the effectiveness. Okay, so you did this part. And here's the bow tie question. Okay, this is where we want to be. So when we think about bow tie, a bow tie could kind of be a standalone question. So in case someone's watching and they're not familiar with it, so this could be like a standalone question, meaning that, okay, this is what you get. All of this information is on one question. So, the telehealth visit, the medications, the lab reports. So you would break it down just like Erica did, looking at, okay, what's normal, what's abnormal, and this is where you can actually use your scratch paper if you need to. I know that we're using whiteboards with dry erase markers now. That's something that you could do if that helps you. And so with this bow tie question, you're going to complete the diagram by dragging the choices below to the specific question, condition that the patient is experiencing, 2 actions the nurse should take to address that condition, and 2 parameters the nurse should monitor to assess the client's progress. Okay, so it's called a bow tie because it has 2 things on the left, 2 things on the right, and then something in the middle, kind of like a bow tie. I don't know who came up with it, but okay, it's a bow
And
tie.
so we do these on Hearst. There's like 6 at the end of every 85 question exam, and you
Oh,
drag up the answers. So you drag like I always do the potential conditions. So I'll drag up like tardive dyskinesia, and then I'll drag up the action to take and the perimeter to monitor. Like it's a drag and drop filling in the bow tie.
okay, so I like your strategy. So let me make sure I understand. So you put the middle one first because I know that this is tardive dyskinesia. So you would put your tardive dyskinesia, and let me just kind of annotate it on the screen in case someone's not verbally following us. So you would put tardive dyskinesia here first, okay? And then from there, you would know what actions to take and then the parameters to monitor because you
Yeah,
know
because,
about tardive dyskinesia.
well, say I put lithium toxicity and I didn't know that we say it was 1.4 or whatever, or I was wrong and I drug up lithium toxicity and then decrease lithium and, evaluate salt intake or whatever. But then I would get over here to perimeter and monitor and be like, oh, those don't really go along with lithium except for
Oh.
hydration. So then I would erase everything real quick and try something else.
Okay, and so that makes sense. Okay, so that makes sense. So I like that strategy. So we're going to put tardive dyskinesia here. And I didn't realize that they were at the end of the Hearst, so that's helpful. Okay, and so what's the action? Well, I know that they're going to stop taking this med because this med is why they have tardive dyskinesia, and I'm going to have to monitor. Okay. Now we're acting like we just have this question by itself and we didn't have all the others because this question is what's called a standalone kind of question. Okay, and so what would I monitor? Well, I'm going to monitor for anything that tells me that the patient has tardive dyskinesia. And just like you said so eloquently that now they're on off of their psychiatric meds, we have to look out for depressive symptoms. So those are going to be the answers. And again, this is a bow tie style question. Okay, all right. That was fantastic. Okay, let me clear this and I'm gonna stop sharing. And I'm gonna ask you, Erica, so what did you think about this? Was it helpful or
This is super helpful. I could do these all day with you. I mean, I don't feel smart when I do them necessarily, but I used to hate the next gen style. However, I'm beginning to understand why we have them because it's not so simple as memorize answer out of four questions. This makes you know your stuff a lot more.
Right. And I think the extra layer of it is the critical thinking piece. And I
Yeah.
know that you have a lot of experience based on your background. So that's kind of a second nature for you. So I know that you'll definitely excel with these kinds of questions. And I'm grateful that you were
No,
here
I like
and
this. This
explaining
is
it.
better than when you're a medic, you just have something called oral boards, is what they call it, and you go in with your medical director. Um, so ours for the region, I know him really well. I know ours for North Carolina really well. And you actually go into a room with them